Good evening again, our dear viewers from all over the world. This is Congenital Heart Disease course at CEC channel. Tonight we are live in Saturday nights for the course, and we have a very interesting webinar tonight about the double outlet right ventricle, the imaging and the clinical scenarios, and the pathophysiology. We have tonight with us honored to have Dr. Amira Noor, lecturer of cardiology at Ain Shams University and consultant of congenital and structural heart disease. And also we have Dr. Hatem Hosni, consultant cardiac surgery at Aswan Heart Center, and Soha Rumeh, consultant of adult congenital heart disease and director of the advanced cardiac imaging program at Aswan Heart Center. Both of them will be moderating this session. And also we have a distinguished visitor tonight, Professor Claudia Montanaro from Royal Brompton. She is specialized in the field of congenital heart disease, and we will have her on board tonight. So thank you everyone for joining us tonight. And please, Amira, start sharing your lecture.
Dr. Zahami. Yes, our topic today will be approach to patient with double outlet right ventricle. Hope we will make it easy by the end, inshallah. First of all, if we revise rapidly the sequential segmental analysis for patient with congenital heart disease, we will find that in the double outlet right ventricle, the abnormality is in the connection between the ventricles and the conal part of the septum or the infundibular conus. So the DORV is one type of ventricular-arterial connection, and mainly due to abnormal connection between the ventricle, the two ventricles, and the infundibular conus. We may have abnormality in the relation of great vessels, or it may be normal. We may have any abnormality in the AV valves. However, this does not go with the definition of double outlet right ventricle. There were many debates about the definition of double outlet right ventricle, and there were many schools like Van Brugge, Curlin, and there was a lot of debate regarding the definition. However, the most accepted definition, or what we use or we go with in our clinical practice, is both great vessels arise from the right ventricle, and using the 50% rule, at least one vessel overrides the interventricular septum by 50%. Or in other words, one complete arterial trunk and at least half of the other trunk arises from the right ventricle. And as we can see from the illustration here, that we have the aorta is arising from the right ventricle, and the pulmonary is arising from the right ventricle, and the aorta overrides the interventricular septum. However, some definition includes that you should have double coni or abnormal conal morphology, or in other words, absence of aortomitral continuity. In order to understand this, first of all, we have to go to the normal, to the structure of the normal heart, where normally we have the pulmonary valve rests on a muscle band, or a conal muscle, a circular conal muscle band. However, the aorta is in fibrous continuity with the surrounding structure, and there is no subaortic conus. Some theories goes with that it regresses during, it was present in the embryology, however, it regresses later on. Some definition includes that you should have double coni or absence of aortomitral continuity. However, while we go through, we will find that this is not a must for patient or for definition of patient with double outlet right ventricle. The final definition that we all use in our clinical practice, according to the Society of Thoracic Surgeon in the year 2000, that it is a type of ventricular arterial connection in which both great vessels arises either entirely or predominantly from the right ventricle. As we can see, there were a lot of debate regarding the definition. However, the aim from our topic or lecture today is to obtain a detailed morphological and functional description for the patient with double outlet right ventricle to formulate the rationale for our surgical approach later on. First of all, I will discuss some anatomical and morphological concentration in the patient with DORV, and consequently the pathophysiology and the clinical presentation in those patients. The most two anatomical parts of patients with double outlet right ventricle is the VSD location, and I stress on location, not the type of VSD, and the relation of the VSD either to the semilunar valves or, in other words, to the great vessels. And the other important anatomical part is the relationship of the great arteries to each other. However, only the VSD location and its relationship to the great vessel is the main determinant component for the pathophysiology and the different clinical classification, as we will see later on for patients with double outlet right ventricle. The first component, as I said, is the VSD. The VSD, we should know that it is the only outlet for the left ventricle. And despite this VSD never closes spontaneously. And according to the location of the VSD and its relation to the great vessels, we will have different pathophysiology, consequently different clinical presentation and different managements for patients with double outlet right ventricle. Again, there was a debate regarding the nomenclature, whether this is a VSD or interventricular communication, regarding the degree of main vessel or great vessel overriding. However, we all agree that we will nominate it or call it VSD or ventricular septal defect. We have 4 types of VSD. Again, I stress on the type, the location of VSD, not the type. We have subaortic VSD, a DORV with a subpulmonic VSD, or a DORV with a doubly committed VSD, or a DORV with non-committed or remote VSD. And we will discuss every type now. Before I go into the details of pathophysiology, I have to discuss an important concept, which is the concepts of flow in patients with congenital cyanotic heart disease. And we are going to discuss only the intracardiac mixing versus the streaming, intracardiac mixing of blood versus the streaming of blood in patients with double outlet right ventricle. For example, this is an illustration for a patient with double outlet right ventricle, and he is having a subaortic VSD. As we said, the VSD is the only outlet for the left ventricle, so the 100% oxygenated blood will be pumped from the left ventricle through the VSD directly into the aorta. And according to the concept of streaming, the streaming of the blood will push most of the blood directly into the aorta with minimal intracardiac mixing, as if 90% of the blood, of the saturated blood, goes to the aorta and only 10% of the blood may mix. And this makes that most of the aortic saturation or systemic arterial saturation will be close to 90% in patients with DORV subaortic VSD. However, the systemic venous blood from the either SVC and IVC goes to the right atrium, to the right ventricle, and passes away from the VSD and pumped directly from the right ventricle into the pulmonary artery to go to the pulmonary circulation. So we have that the desaturated blood will be pumped into the pulmonary artery and undergo oxygenation. So actually this pathophysiology is very close to those patients who are having a large VSD. As we can see that the effect of streaming here in this patient is beneficial. However, on the other hand, if we look close to the pathophysiology and patient with, this is an illustration for a patient with DORV subpulmonic VSD. Here is again the 100% oxygenated blood will be pumped from the left ventricle through the subpulmonic VSD into the pulmonary artery, and the desaturated blood from the systemic veins to the will be pumped from the right ventricle to the aorta. So here, as if we are having two separate or two circulation that are in series and not in that are in parallel and not in series. So the desaturated blood will go to the aorta, and the saturated blood will go to the pulmonary artery, and this is very close to the physiology of patient with transposition of great arteries. I mean the DTGA or TGA with Maleposed great vessels. And actually, this is an unfavorable effect of streaming, because those patient presents early with cyanosis and marked desaturation. So a clinical tip here that those patients, despite they are having a VSD, they should undergo a Rushkin procedure or balloon atrial septostomy in order to improve their intracardiac mixing till the time of the surgical procedure or management. After I discussed the concept of streaming and intracardiac mixing, and actually in patients with DORV subaortic VSD or DORV subpulmonic VSD, the concept of streaming is predominant than the intracardiac mixing. So we could understand that this patient with a DORV subaortic VSD, they will present early as a patient as if he is having a VSD. So they will present with failure to thrive, recurrent chest infection, congestive heart failure, and later on, as the pulmonary artery have the lower resistance, or the pulmonary vascular resistance at first is markedly low than the systemic resistance, so the blood will preferentially flow into the pulmonary artery, and later on they will develop pulmonary hypertension. However, in certain types of DORV with subaortic VSD, there will be an anterior encephalic deviation of the conal part of the septum, causing a subpulmonic or pulmonary valve obstruction or pulmonary stenosis. And if we look carefully to this type of DORV with subaortic VSD and pulmonary stenosis, we will find that it looks closely like a patient with tetralogy of Fallot. They are having the same pathophysiology and the same clinical presentation. They present also with cyanosis shortly after birth. So this type, sometimes we call it a DORV Fallot type. The other type, the second type of the DORV is the DORV with a subpulmonic VSD, and sometimes we call it Towson-Bing anomaly. And as I said before, the concept of streaming of the blood is also applied to this figure, where here the VSD is subpulmonic or mostly committed to the pulmonary artery. So those patients will present early with cyanosis, and their clinical presentation will be typically like as if it is a patient with DTGA. In some patients with DORV subpulmonic VSD, sometimes we have, it may be associated with subaortic or aortic stenosis, or a systemic outflow tract obstruction in the form of coarctation or hypoplasia or hypoplastic arch. So whenever you look for a patient with, or you identify a patient with a DORV subpulmonic VSD, you should look carefully for any systemic outflow tract obstruction or aortic coarctation or hypoplasia of the aortic arch. The third type of the DORV is the DORV with doubly committed VSD, and here we have the VSD committed to both arteries. So the clinical picture will be, or will look like a patient with a large VSD, and they also later on develop pulmonary hypertension. And the fourth type is the DORV with a non-committed VSD or remote VSD. The DORV with a non-committed VSD, actually, I mean that the VSD is not committed to any of the great vessels, so it is far away from the great vessels. And actually, we have here two types of VSD, either it is a muscular VSD or an inlet VSD. However, there was a debate what is the rule or the measurement for the distance of the VSD from the aortic annulus or from the aortic valve to identify that this is a remote VSD, or how remote is the VSD, how remote to say that this is a non-committed VSD. I would like to hear the answer from Dr. Hatem, if he is with us. Dr. Hatem?
Thank you, Amira. This has been very comprehensive. Thank you. So, talking about remote VSD, again, this is very relative. So people tend to try to essentially baffle any VSD to the nearest great vessel so that we achieve eventually two ventricle repair, as you'll probably go later. But very generally, with the VSD to valve you approach is more than this valve annulus. So let's assume that we want to direct this VSD into the aortic valve. If the distance from the edge of the VSD to the aortic annulus is more than the diameter of the aortic annulus, then we assume that this is a relatively remote VSD.
Okay. Thank you, Dr. Hatem. This is very illustrative.
Just to summarize,
yes.
Amir has been discussing very clearly the four major subtypes of the double outlet right ventricle, and stressing that the relation of the site or the location of the VSD to the great vessels is of a great importance. And this is probably reflected in pathophysiology, presentation, and management of these patients. So the VSD, which is essentially the only outlet of this left ventricle. So if the VSD is either related to the aortic valve, to the pulmonary valve, related to both, or related to none, so away from both. And then a big importance is related to if there is any outflow tract obstruction, either subpulmonic or subaortic obstruction.
Yes.
Is that correct, Amir?
Yes, totally.
Thank you very much. Go on.
Thank you. Actually, in some literature or some books, they said that there is a fifth type for those patients with double outlet right ventricle, and we can call it is a complex type, where you can find that the patient is having a double outlet right ventricle, and it is associated with asplenia syndrome or right atrial isomerism, or you have a patient with double outlet right ventricle and he is having either partial or total anomalous pulmonary venous drainage, or a patient with common AV canal and double outlet right ventricle. So we can call it this is a complex type of patients with double outlet right ventricle. I would like to summarize again what Dr. Hatem stressed on, that we have mainly four subclinical types or subtypes for patients with double outlet right ventricle, and we can add a fifth type, and they mainly depend on the location of the VSD, not the type of VSD, either subaortic, subpulmonic, doubly committed or not committed, or related to the great vessels. The patient with the subaortic VSD without pulmonary stenosis, their pathophysiology and clinical presentation looks so much closely to a patient with a large VSD, and a patient with a DORV subaortic VSD with pulmonary stenosis, his clinical presentation and pathophysiology looks closely to those patients with tetralogy of Fallot, and patient with a subpulmonic VSD, DORV with subpulmonic VSD, their pathophysiology and clinical presentation looks very similar to patient with DTGE, and we call it Towson-Bing anomaly. Patient with a doubly committed VSD, their clinical presentation and pathophysiology also looks close as if this patient is having a large VSD. Actually, I will go through some anatomical details for patients with double outlet right ventricle. They don't have so much clinical implication or surgical or different management But however, we should know these anatomical details. I will go through the relation of the great vessels in patient with double outlet right ventricle. Actually, we may have normally related great vessels, and this is commonly seen in patient with DORV subaortic VSD, or the great vessels may be side by side. And actually, we can see them in patient, we can see this type in patient with DORV subaortic VSD or DORV subpulmonic VSD. And we can see the Maleposed relation of the great vessels also in patient with DORV subpulmonic VSD, where the aorta is anterior to the right. We can have an antero-posterior relationship between, or antero-posterior relationship between the aortic valve and the pulmonary valve. And less commonly, we can have an Maleposed great vessels where the aorta is anterior and to the left of the pulmonary artery. Another anatomical consideration, I will go rapidly through it. Actually, I said previously in the definition that some definition is stressed on the presence of double coni or absence of aortomitral continuity in order to define that this patient is having a double outlet right ventricle. However, we find that we have different variation or different morphological features for the conal septum in patient with DORV. We can have a double coni in patient with a remote VSD. We can have an absent coni in patient with doubly committed VSD. We may have one conus present and the other is absent. For example, we may have an absent subaortic conus and present subpulmonic conus, and vice versa. This is also doesn't have any clinical application. However, sometimes during the surgical management or approach, if the conal septum is very prominent, the surgeon have to resect it in order to give him a space to establish a good tunnel or a good baffle without obstruction or stenosis. Again, I would like to revise.
Yes, thank you very much for clarifying.
Yes.
So thank you for clarifying. I just want just to clarify for myself and our colleagues, and not to get confused. So you've been talking about the location of the VSD, or the relation of the VSD to great vessels.
Yes.
But you've also touched on the relationship of the great vessels to each other.
Yes.
And the presence or absence of conal septum.
Yes.
I do acknowledge that these 3 points are actually important in planning management, but which of these determine the subtype of?
Yes. Yes, Dr. Hatem.
Of the DORV would go.
Yes, again, I would like to stress on that the VSD location is of utmost importance in determining the subtypes of patient with double outlet right ventricle, for determining, as we said before, the pathophysiology, clinical presentation, and management, regardless of the relation of the great vessels. You may have a patient with a subaortic VSD, normally related great vessels, or the vessels are side by side. Actually, this doesn't affect the clinical presentation. The most important issue, or the most important factor in affecting the pathophysiology, presentation, and management is the location of the VSD and its relation to the great vessels. Yes, I am to the point, Dr.
I
Hazen.
agree. I agree, because if the VSD is below the aortic valve, then the blood coming from the left ventricle will be mostly streaming into the aorta, while if the VSD is below the pulmonary valve, again, the oxygenated blood coming from LV will be mostly streaming to the pulmonary. Regardless the relationship of great vessels, usually the DORV with subaortic VSD, the great vessels are normally related. Usually with DORV subpulmonic VSD, great vessels are Maleposed, but again, this is not the essential determining factor for the plan of management. The plan of management is where is the VSD in relation to the great vessels, and not the relationship of great vessels to each other.
Yes, yes, Dr. Hatem. Yes,
Thank
thank you so much. Thank
you. Someone from our colleagues have been asking about what is the difference between DORV subpulmonic VSD, Tausig Bing, and DTGA.
Between the DORV
Can
and
you
the patient
clarify
with
this?
DTGA?
Yeah, DORV. What is the difference between DORV,
Yes, and
TGA, and
yes.
Tausig Bing? Are they different things or are they the same? What's the difference?
Yes, actually, the patient there's no a term called DORV DTGA. It is a DORV double outlet right ventricle patient with subpulmonic VSD, and this is called a Towson-Bing anomaly, regardless of the relation of the great vessels, and its pathophysiology is very close to the patient with DTGA. But there is no, I don't think there is a term called DORV DTGA. Yes, Dr. Hatem?
So, yes. So, Tausig Bing
Yes.
heart. The Tausig Bing heart is the heart with DORV
Yes.
and subpulmonic
DORV.
VSD.
Subpulmonic VSD.
Exactly.
Yes.
And what's the difference between that and TGA? Acknowledging that they are the same physiology. Actually, in your slide that showed all the subtypes of the DORV. Why do we need actually to differentiate between DORV VSD and the VSD as an entity? DORV fellow and the fellow, DORV TGA and the TGA. So is there a real difference?
Yes. I think the main difference, I will discuss this later in the coming slides.
Okay,
the difference between the fellow and DORV subaortic DSDPS, I will discuss it later. But the most important issue, I think, is the degree of overriding, as I will discuss later on. Okay?
Thank you. Thank you very much. Great.
I will go through the associated lesions with patients with double outlet right ventricle. We discussed some of them. As we said, the patient with DORV subaortic VSD, they may have an outflow tract obstruction in the form of subpulmonic or pulmonary stenosis. And patient with DORV subpulmonic VSD, they may have an aortic systemic outflow tract obstruction in the form of aortic stenosis, coarctation, hypoplastic arch. Another associated lesions we could identify in this patient is we may have an AV valve anomalies in the form of overriding or straddling mitral valve or overriding or straddling tricuspid valve. Very rarely we can see patient with DORV and mitral valve atresia. So these can be associated anomalies. I will discuss in details the coronary anatomy in patients with double outlet right ventricle. Usually, the coronary anatomy is normal in patient with double outlet right ventricle, as in patient, for example, in patient with DORV subaortic VSD, we have normally related great vessels, and consequently, the coronary anatomy will be normal. However, we should put in mind that the coronary anatomy may be abnormal in some case. For example, in some cases with DORV subaortic VSD, pulmonary stenosis, which look closely as if to the patient with tetralogy of Fallot. For example, you may have a coronary crossing the RVOT and LAD arising from the right coronary artery and crossing the RVOT. So you should carefully and clearly identify the coronary anatomy either by echocardiography, if not possible by multi-slice CT. And also the coronary anatomy, some may be abnormal in case of DORV subpulmonic VSD or Towson-Bing anomaly. As the same abnormalities as we can see in patient with DTGA. However, the coronary anomalies are more commonly seen in patient with DORV subaortic VSD pulmonary stenosis rather than tetralogy of Fallot, and in patient with DORV subpulmonic VSD rather than those with TGA, as for example, the great vessels may arise side by side, and this will make or this will cause a lot, or maybe associated with a lot of coronary anomalies, or much more commonly associated with coronary anomalies.
And actually, in these cases, coronary abnormalities are really clinically significant because they might affect the surgery, because they can be in the pathway, or like in the tetralogy of Fallot, or as you said, if some intramural coronaries in the Towson-Bing, and then if we plan to do an operation like the arterial switch, this can be really clinically significant there.
Yes. Another point of an important surgical application is that the distance between the tricuspid valve and the pulmonary valve. If the distance between the tricuspid valve and the pulmonary valve. I mean, if the distance between the tricuspid valve and the pulmonary valve is short, less than, for example, the aortic valve annulus, this will make the tunnel or baffle from the LV to the systemic to the great vessel will make it difficult or may cause an obstruction in the way of the baffle. So this is an also important. Do you hear me quite well, Dr. Hatem?
Yes, I hear you very well. Thank you.
Okay, because I'm having some technical problems.
I hear you very well, Amira. Your voice is very clear.
Yes.
No problem at all.
Okay, Dr. Zahram. But I'm having some technical problems with the presentation. I don't know.
I will stop sharing and
yes, and reshare again.
Okay. If you stand on a slide for some times, because we are live streaming, usually it stops sharing and you can reshare again.
Okay.
So while Amira joins us again, Dr. Hatem, I would like to ask you a simple question from the YouTube. Dr. N was asking us, what is the difference between Maleposed and transposed vessels? While Amira starts sharing, maybe Dr. Hatem can help us.
So this is a more of a semantic difference. So it's mainly nomenclature. So transposition is one type of ventriculo-arterial connections, which means that the aortic valve comes from the left ventricle or the right ventricle. So in transposition, the aortic valve comes from the right ventricle, while the pulmonary valve comes from the left ventricle, which is ventriculo-arterial discordance. If the patient does not have a proper so double outer right ventricle is another type of ventricular artery to describe that the relation of the great vessels is the opposite of normal, the abnormal. So we say Maleposed great vessels rather than transposed. Essentially, it is the same, but we're just making sure that everybody is clear that the ventriculo-arterial discordance is a DORV rather than the proper transposition. So it's more of a nomenclature and semantic thing, which is actually quite a lot in the congenital.
Okay, Dr. Hatem.
I hope I'm clear.
Going back to the presentation, this is the illustration of what I have just discussed about the distance between the tricuspid valve and pulmonary valve. And actually, I think this is having an important surgical application. If this distance is quite smaller than the aortic valve annulus, for example, this may affect your tunnel or baffle from the VSD to the aorta. Right, Dr. Hatem? Dr. Hatem.
Sorry, I lost connection for a second. Would you repeat that again?
Okay. Yes, this is the illustration for what I have been discussing, that if the distance between the tricuspid and the pulmonary valve is small, for example, it is less than the aortic valve annulus, it may obstruct your baffle from the left ventricle to the aorta through the VSD. Does this have a surgical application again? Do you want to discuss this point?
Honestly, it does. So as you will elaborate later, we connect the VSD to the nearest great vessel.
Yes.
And then we see if this connection is the correct one or the opposite, and then we switch. So if the VSD is near to the aortic valve, we connect the VSD into the aorta. So rather than closing the VSD so that the left ventricle will have no outlet, we actually baffle the VSD into the aorta. And so the LV will be connected underneath that baffle into the aorta, while the right ventricle will just give the pulmonary. If the pulmonary valve actually gets nearer to the tricuspid valve so that the pathway from the VSD into the aorta is narrow, this will essentially cause LVG obstruction, because the tunnel from the VSD to the aorta will be long and narrow, and then this has really bad prognostic outcome. So on the other hand, if the VSD in this situation is nearer to the pulmonary valve, then you might just as well connect the VSD into the pulmonary valve,
Yes.
transforming that patient into a proper TGA. And then, so on the other hand, conal septum is the septum which separates the entry into the aortic root and
Yes.
entry into the pulmonary root, and then it can be in this pathway and can be quite prominent. So this can obstruct the pathway from the VSD to either great vessels, and in these cases we might as well need to resect some part of this conal septum. So yes, the distance between the VSD and great vessels is significant, and this pathway, this whole pathway and its diameter again is significant. So we need at least that the pathway is at least as equal as like the diameter of the annulus that the VSD is directed to, so that there's no pathway obstruction in the middle.
Okay, thank you, Dr. Hatem. Thank you so much. Then we will move to imaging of the patient with double outlet right ventricle, of course, by echocardiography. I would like to address that we have a checklist. If you define by the echo that this patient is a patient with double outlet right ventricle, according to the definition that I discussed before, that both great vessels arise either entirely or predominantly from the right ventricle. So first of all, you define by your echocardiography that this patient is having a double outlet right ventricle. Then you should go through this checklist. First of all, assessment of the location of the VSD, and again we stress that this is of utmost importance, and the VSD, the location of the VSD and its relation to the semilunar valves or great vessels. And also quite important is the size of the VSD, whether it is a small VSD or a large VSD. And there was a lot of debate about how small is the size of the VSD. And again, we relate it to the aortic valve annulus. If the VSD is more than the aortic valve annulus, then it is a large VSD. If it is smaller than the aortic valve annulus, it is a small. And as we said, that the VSD is our only outlet for the left ventricle, so this patient will have an LVOT, a significant LVOT obstruction. The second point is after identifying the VSD and its location and size, the relation of the grade. You should identify the relation of the great vessels to each other. Is there any outflow tract obstruction, as we discussed before, pulmonary stenosis, aortic stenosis, aortic coarctation, hypoplastic arch, and after fulfilling all these points, you look for the associated lesions as I discussed before, and of course the coronary anatomy if possible. And I will discuss with you some echocardiographic clips for patients in our echo lab with double outlet right ventricle. This is a subpostal view where we can see here that the right ventricle is giving rise to two great vessels arising side by side, mostly arising entirely from the right ventricle. So first of all, as I said, we define that this patient is a patient with double outlet right ventricle. The second point in the checklist is the location of the VSD and its relation to the great vessels. This is a subpostal view showing that this patient is having a large VSD, is having a large subaortic VSD. Here is the aorta, and this is the aortic valve, and there is a large subaortic VSD, and in the corresponding parasternal long axis view, the VSD is also subaortic. And here we can see that the pulmonary artery or the pulmonary valve is not related at all to the VSD. So this patient was with a DORV subaortic VSD. And this is another example for patient with another type of VSD. where we can see here that the right ventricle is giving rise to two great vessels, and here is the this is also a subcostal view. We can identify that the VSD is subpulmonic or related entirely to the pulmonary valve, and in the corresponding parasternal long axis view, we can also identify that the VSD here is subpulmonic or related to the pulmonary valve. So this was the first point in our checklist, the location of VSD and also its size. The second point, is there a pulmonary stenosis or outflow tract obstruction or not? Actually, this patient is having here a color flow aliasing across the post-great vessels, of course, are arising from the right ventricle, and he is having a color flow aliasing, indicating that this patient is having a subvalvular and valvular pulmonary stenosis. So this patient was a double outlet right ventricle patient with subaortic VSD and pulmonary stenosis. The second point in our checklist is to identify whether there is a pulmonary stenosis or not. And the third point in our checklist is to identify the relation of the great vessels. Here we can see that the pulmonary valve and the aortic valve are mostly arising side by side with the aorta slightly anterior. So here the relation of the great vessels is side by side. And I will show you another form for a great, another form for great vessels. Here we can identify that here is another form of a relation of the great vessels, where we can identify that the pulmonary the normal relationship of the great vessels, the circle and sausage form. Here is the pulmonary valve and here is the aortic valve. Actually, this is a very interesting echo, where we can see that this patient is having this patient was DORV subaortic VSD pulmonary stenosis, and he was having very interestingly a coronary artery, mostly in LED, arising from the RCA crossing in front of the RVOT. So this was very interesting. So again, I stress on the checklist when identifying a patient with a double outlet right ventricle using echo. First, the location of the VSD and its size. Is there a pulmonary stenosis or not, or outflow tract obstruction or not? The relation of the great vessels to each other, and any associated lesions, and if you can identify the coronary anatomy. Actually, Dr. Hatem asked me a question, or maybe one of our viewers, what is the difference between the tetralogy of Fallot and the DORV with subaortic VSD pulmonary stenosis, or the difference between the patients with DTGA and DORV subpulmonic VSD or Towson-Bing anomaly? Actually, the main difference is the degree of aortic overriding. As if the degree of aortic overriding is more than 50%, I mean the aorta overrides the interventricular septum by more than 50%, this goes with the DORV subaortic VSD PS. However, if the degree of overriding is less than 50%, this goes with the tetralogy of Fallot. However, I said their clinical presentation and management is very close to each other. The coronary, another point that the side-by-side great vessels are more commonly seen in patients with DORV subaortic VSD. Patients with DORV subaortic VSD may sometimes have more associated coronary anomalies than patient with tetralogy of Fallot. And another point for the difference between patient with DTGA and DORV subpulmonic VSD or Towson-Bing anomaly, again, is the degree of overriding of the pulmonary valve or the pulmonary artery, where in the patient with DTGA, the pulmonary valve exclusively arises from the left ventricle. However, here the pulmonary valve or the pulmonary artery overrides the interventricular septum in patient with DORV subpulmonic VSD. Another difference is that we have, again, the great vessels may be more side by side in patients with DORV subpulmonic VSD rather than Maleposed great vessels. We will have more coronary anomalies associated with the patient with DORV subpulmonic VSD, and we said that the patient with DORV subpulmonic VSD commonly associated with left ventricular outflow tract obstruction or aortic coarctation or hypoplastic arch, so it should be looked for. Dr. Hatem, would you like to add something?
So again, summarizing what Dr. Amira has just said, so the main difference between any entity and its DORV counterpart is the degree of overriding. So as exactly she exactly said during the definition of the double outlet right ventricle. So both great vessels predominantly come out from the right ventricle, which usually entails that one great vessel totally comes from the right ventricle and more than 50% of the other great vessel. Does that make real clinical significance? It does, although the physiology presentation and management, there are some subtle differences. The tunnel of closing the VSD into that great vessel is significantly harder than just closing a VSD in a patient with a normally connected heart. The probability of this tunnel getting obstructed either immediately after operation or with time when the patient grows older, and this tunnel can get smaller, so they have more probability of getting LVOT obstruction. And in entities like the Tausig-Bing, again, repeating what Amira said, they are more prone to get side-by-side great vessels, which makes the arterial switch slightly more difficult. They are more probable to get abnormal coronary patterns, sometimes single coronary, sometimes intramural coronaries. So again, making the switch harder, and can get subaortic stenosis because of the coronal septum narrowing the entry into the aortic valve. So they can very well be associated with hypoplastic aortic arch, which again trans arterial to the VSD. Thank you, Amir.
Okay, thank you so much, Dr. Hatem. I would like to give a hint. We discussed now the patient was double outlet right ventricle, and sometimes a lot of echocardiographic congenital echocardiographers or imager are asking if this is there a patient with double outlet left ventricle. Actually, it is quite rare to have a patient with double outlet left ventricle, and you should revise yourself and be sure from the morphology of the ventricle before identifying or saying that this patient is a patient with double outlet left ventricle, because it's quite rare, as what is known in embryology, or what is actually in embryology, that we all have double inlet left ventricle with double outlet right ventricle. Actually, we have the common arterial trunk. First of all, mostly they are like two parts a little bit away from each other or on two different planes. So the inlet is more like to a double inlet left ventricle, and the outlet is more like to a double outlet right ventricle. So if it goes with the embryology, double outlet right ventricle is quite common. And if you find a ventricle where both great vessels are rising entirely or predominantly, mostly 95% of the cases, it will be a double outlet right ventricle. However, if it is a double outlet left ventricle, you will go through the same echo checklist that I discussed before. Now, finally, we will go to the management for patients with DORV. Actually, the goals for surgery, as Dr. Hatem said previously, is to close the VSD, not to close the VSD and leave the left ventricle without an outflow, because we said it is the outflow for the left ventricle, but you should tunnel or baffle the blood flow from the left ventricle to the aorta. And the third important point, if you are having an pulmonary valve obstruction, or if you are having an outflow tract obstruction, you should establish a patent RV to pulmonary artery connection. And another important point, that biventricular repair, if possible, is preferred than univentricular repair. If you can do a biventricular repair, it is better, of course, than univentricular repair. If you can do a single stage repair, of course, it will have a better outcome than a staged procedure or operation. However, as Dr. Soha said in the previous lecture, when discussing the single ventricle, to have a good, in some cases where we couldn't do a biventricular repair, to have a good univentricular repair is better than to have a bad biventricular repair. Going a little bit with more details through the surgical procedure. To summarize it, I just will give only some points. If you are having a patient with subaortic VSD or doubly committed VSD without pulmonary stenosis or outflow tract obstruction, you can just baffle the blood from the LV to the aortic valve. However, if you are having a patient with subaortic VSD or doubly committed VSD and pulmonary stenosis or outflow tract obstruction, you will have to baffle the blood from the LV to the aorta and then establish or do an outflow tract obstruction, or sometimes you may have to make an RV to pulmonary artery conduit. In case of patient with subpulmonic VSD or Towson-Bing anomaly, as Dr. Hatem said, it will be more, more sensible or more close to our thinking rather than to baffle the VSD to the aorta, is that you can baffle the VSD directly to the great vessel that is above it, which is the pulmonary, and then do an arterial switch operation. So you baffle the blood from the LV to the pulmonary artery and then do the arterial switch operation. If it is associated with aortic coarctation, you can do a coarctation repair. Finally, actually, the remote VSD is one of the most difficult, despite we are having two well-formed ventricles. However, the surgical approach is very difficult. And I would like to hear from Dr. Hatem, what are the surgical options or solutions that are available for those patients with DORV and remote VSD?
The aim of the DORV repair is that we connect the LV into the nearest great vessel, and separating that from the RV, so that we establish two ventricle repair. If the VSD is really remote from the great vessel, let's assume that in such patient where he had a predominantly an inlet VSD or an inlet muscular VSD, underneath the tricuspid valve, very far away from both aorta and pulmonary. And this is the only outlet from the left ventricle. Everybody tries very hard to establish two ventricle circulation, assuming that this is a better longer term outcome. So to be able to connect this VSD into the far away great vessel, we essentially will have to put a proper tube, because it is very hard to go like a tunnel all that pathway along the tricuspid cords. So you may be tempted to put a tube graft inside the RV cavity, nearly almost totally obliterating the tricuspid valve inflow into the right ventricle, having to go a long pathway into the aorta, and then the VSD LV tube obstruction, and then you run a very high risk of getting heart block. So a baby comes 3 months, 5 months old, who has an inlet VSD, and then you get very enthusiastic and connect that inlet VSD into the aortic valve, and you get significant tricuspid stenosis, long pathway, which is relatively stenotic but not much, to be able to achieve that, quite a small baby. So you open a big right ventriculotomy to have good visualization of both the VSD and the great vessel, and you essentially establish a two ventricle circulation with the big ventriculotomy obliterating a lot of the RV cavity. And then a few months later, the baby grows older, And actually he did the operation while he was 3-4 kilos, and now he is 10 kilos. So now the LVOT is obstructed because this tube graft is getting smaller for the baby. And now he has significant LVOT obstruction in addition to the heart block. And you want to do a reoperation, do another large right ventriculotomy, and try to do a larger conduit. This is not a nice life to live. These patients do lots of reoperations. They have bad two ventricle circulation with significant LVT obstruction, RV obliteration of the cavity, impairment of the RV inflow. This is not the good circulation that you want for the long-term prognosis. So a good single ventricle repair is a lot better than bad two ventricle repair. That's exactly what Amira said.
Yes, okay, thank you, Dr. Hatem.
So these patients probably will live a lot better if they get good single ventricle strategy.
Okay, Dr. Hatem. And I think sometimes we in patients with double outlet right ventricle, despite that biventricular repair is the best option, sometimes we have to go for palliative procedures. For example, if we have a diffusely small pulmonary arteries or a hypoplastic or pulmonary tree, we have to increase the pulmonary blood flow. So at this point, we have to do a staging procedure. We have to do an MBT shunt, or if a patient presents quite a bit late and he is having now an unprotected pulmonary circulation with pulmonary hypertension. So I think we have to do first pulmonary artery bending before going for biventricular repair. Do you agree, Dr. Hatem?
So in some patients, assuming that the VSD is not really remote, but it's a bit a relatively long tunnel. So let's assume a patient who has a double outlet right ventricle with a subaortic VSD, but the tunnel will be relatively long. So instead of doing a long tunnel in a very small baby with high risk of obstruction when the baby grows, one other strategy might be to do a pulmonary artery bending now, so that the pulmonary arteries, pulmonary circulation is protected. You allow the patient to grow older, and then you do that long tunnel when the baby is like 10, 12 kilos. So you get better visualization and less risk of outflow obstruction. Again, this is not the rule. This is judged by a case-by-case basis. Many of these patients have CT imaging, so that we can have a look on the 3D reconstructed, sometimes 3D printed images, so that we can plan ahead how far is the VSD, what is crossing in the middle, and are we comfortable doing this, or do we want to defer this for a later age?
Okay, Dr. Hatem. Thank you so much. Dr. Soha is with us? Okay. Yes, Dr. Hatem.
I believe she had some connection problems. She just mentioned.
Okay, Dr. Hatem, thank you. I just want to summarize again the approach for a patient with double outlet right ventricle. As you marvelously illustrated them, if we have a patient with DORV subaortic VSD or committed VSD without pulmonary stenosis, actually we will do will we close the VSD as if this patient, or we will manage him as if he's having a VSD. The patient with DORV subaortic VSD pulmonary stenosis, he will be managed at those patients as if he is a patient with tetralogy of Fallot in the same manner and in the same approach as we discussed before in the lecture of tetralogy of Fallot. A patient with DORV subpulmonic VSD, he will be also closely managed and his surgical approach will be close to a patient with DTGA. And if a patient is having a doubly committed VSD, Also, we said a doubly committed VSD without pulmonary stenosis, we will just close the VSD or tunnel it to the aortic valve, or if there is a pulmonary stenosis or pulmonary obstruction, we will try to make an RV to pulmonary artery conduit. And as Dr. Hatem said, those patients with non-committed VSD, biventricular repair will be very difficult. So we would rather go for a univentricular repair to have a better outcome for those patients.
So sorry, Amira, we just had a comment that my voice was lost during the talking about the remote VSD. I'll just give a very brief summary. So if the VSD is remote, and to be able to connect the remote VSD to the nearest great vessel, this will markedly affect the physiology. I mean, obliterating the RV inflow, or narrowing the RV cavity, or getting heart block, or cutting some tricuspid cords, or getting LVOT obstruction, then we should not do that. And we can alternatively do a single ventricle repair. Although these patients do have two good ventricles, they do better with a single ventricle physiology rather than having real problems with multiple reoperations with impaired right and left ventricular function to just achieve two ventricle repair.
Yes, Dr.
So
Hatem.
again, this is also judged as case by case scenario. So judging when is it remote and when is baffling that remote VSD to the nearest great vessel is very relative, depends on center experience, but also on sensible judgment for each case.
Yes, Dr. Hatem. Actually, I want to stress on another point. If we, for example, if we have a clinical scenario of a 2 weeks old baby presented with Towson-Bing anomaly or DORV subpulmonic VSD, his saturation is 65 to 70%. So do we have a rationale for a Rushkin procedure or balloon atrial septostomy despite this patient is having a large VSD, a large subpulmonary VSD?
So you might think that a patient with a large VSD should have good mixing. So not necessarily why would such a patient have very low saturation? But as mentioned, streaming can be very severe in these patients. So most of the blood going into the aorta is originally coming from the right ventricle. Very small amount of oxygenated blood comes from the left ventricle because of the extreme streaming. So yes, these patients can be very cyanotic. On the other hand, it's the same argument as do we need to do a balloon atrial septostomy for any TGA or not? So if this patient is already in a center who is capable of doing arterial switch, you just go for the arterial switch without doing a balloon septostomy first. But on the other hand, if for any reason the surgery has to be delayed, or if this center is not capable of doing such an operation and the patient needs to be transferred for long distances, then it can indeed be unsafe to keep the patient. You do balloon atrial septostomy, and interestingly, the ASD created is usually much smaller than the size of the VSD, yet the saturation significantly improves. It is the difference between mixing and streaming.
Okay, thank you, Dr. Hatem. I just would like to give our take-home message for this interesting topic. Again, the VSD location and its relation to the great vessels is essential for the clinical classification of the DORV patients. And as I discussed before and stressed again with Dr. Hatem, that the concept of a streaming of blood flow is very important or essential for the clinical presentation of patients with DORV subaortic or subpulmonic VSD. And as I said before, we may have the streaming effect of blood may have a favorable outcome in patients with DORV subaortic VSD as they have a better saturation, almost close to 90%, or an unfavorable outcome in those with patients with DORV subpulmonic VSD where they present with marked cyanosis and desaturation. And again, balloon atrial septostomy, if the surgery couldn't be done as early as possible, should be done in patients with DORV subpulmonic VSD. And again, I stress on don't miss any item from the echo checklist I discussed or illustrated for patients with double outlet right ventricle, so as not to miss any anatomical or any component in patients with double outlet right ventricle. And finally, the different clinical types of DORV are amenable, as we discussed, for biventricular repair, except in limited cases or limited case scenario. Thank you so much. Do you like to add something, Dr. Hatem, before we end?
Thank you very much, Amira. I really enjoyed your talk. Thank you.
Thank you. Thank you so much, Dr. Hatem.
So thanks a lot, Dr. Amira, for this really nice talk involving all the details for the double outlet and the different forms and morphologies for the double outlet right ventricle clinical scenarios. And Dr. Hatem joined us also with the different surgical techniques for each particular situation. This was really important to put this webinar at the end of all the different congenital heart diseases, because as we have seen, usually understanding the double outlet right ventricle as a clinical syndrome, which type of disease is actually going towards this double outlet right ventricle, and this accordingly the plan of surgery will be decided. So thank you so much, Dr. Hatem, Dr. Soha, Dr. Amira, and thanks Dr. Claudia for joining us tonight. Actually, next Saturday and the Saturday afterwards, we will be discussing the two final webinars, the grown-up congenital heart disease or the adult congenital heart disease. And luckily enough, we got the new guidelines from the European Society of Cardiology. We will be structuring a very interesting webinars with Dr. Soha, Dr. Hatem, and all the other members, and Dr. Claudia, and all the other members of the congenital heart disease team. We will be discussing the different clinical scenarios and incorporating those guidelines into the practice through easily understandable clinical scenarios for this grown-up congenital heart disease sector. So thank you all for tonight. I have enjoyed this session so much, and also getting very positive impact from our viewers. And next Saturday, we will be meeting you also with the grown-up congenital heart disease. So
Thank you, Doctor.
thank you so much.